Dr. Podgorski is an associate professor of psychiatry here at the University of Rochester and has a PhD in sociology and a master's in public health and marriage and family therapy. And I've had the pleasure to work with her and share several patients as we've been doing more neuropalliative care with the memory clinic. She has a lot of directory roles, including director of the Finger Lake Center of Excellence in Alzheimer's, co-director of family therapy training, clinic director of the UR Medicine Memory Care Program, and associate director of the Office for Aging Research and Health Services, and really provides critical support for our patients, but particularly our families who are affected by dementia. And so per wishes of our group to learn more about counseling and how we could potentially develop more skills on the front line, wanted Carol to join us and give her her perspectives and expertise. So thank you for joining us.
Thank you for inviting me. There we go. Okay, so I have no conflicts of interest to declare. I'm hoping by the end of our time together that you will walk away with maybe a deeper understanding of how chronic neurologic illness affects family relationships and how family relationships affect chronic illness. I'd also like to share a little bit about how family dynamics impact care delivery or your treatment planning, and identify a couple of resources or strategy that I hope will help you in supporting your work with families. So I'd like to start with this quote, because I think it grounds us. My husband's stroke has been the most devastating experience of my and his life. First, you have to rebuild the survivor and their life, then your joint lives together. And if you have any energy left, you can have a go at remembering who you are. I think that it's clear that there's this sense of unraveling that happens in families when a chronic illness enters. I'm trying to move you all so that I want to kind of see you, but okay. So when a chronic illness occurs, there are a lot of family changes that happen. And I know that when I do family therapy in the memory care program, I always say that when dementia enters a family, it knocks things off balance, and everybody usually shakes their heads with understanding. And that's what I want to talk about today, really. We know that there are a lot of family changes that happen when an illness occurs in a family. Power dynamics shift, roles change, how people spend their resources change. There's a lot of anxiety, mood disorders that happen. And it's often pretty lonely and isolating for families. So this is a weird little thing that I developed a long time ago, but I think I developed it to describe a family's response to a chronic illness. And I think we all have had an experience of our own chronic illness or someone else in our family with a chronic illness. And when you start to suspect that this illness is going to happen, you become very laser focused on it, right? Families often read about it. They read everything they can get their hands on. It becomes the focus or organizing principle of their life for a time until they really figure out what it is. I know in dementia, for example, people often try to spend maybe 1 or 2 years explaining it away as something other than what they hope it isn't, right? So people get very, very focused on it. But I think that this is a good thing when people get focused to go into what I call the illness bubble. So once they're in there, what happens? So first, that's the place where people go when they experience shock and can't believe this is happening to them, or how their lives changed in a minute or whatever. They start to grieve losses or put their new life into perspective. Think about how to make sense of the illness, whether it's spiritually, genetically, or whatever. Why did this happen to us? His bad behavior, whatever it happens to be. It's how family will come together to think about coping strategies. and how to live with uncertainties, which so often accompanies these types of illnesses. People have important conversations. They might put legal or financial plans in place, and then talk about how to deal with this thing. Who do we want to tell about it? Who should be the messenger? What will the message be? These are all things that I think happen in that bubble. So in the shock and disbelief part, that's the why me? Could the doctors be wrong? Let's get a second opinion. Let's look for other explanations for what might be going on, because we're not going to just accept this if it's altering our lives. We want to make sure. And then there's grief and loss of your former self, of roles that you held, maybe a job you had, use of how you wanted to spend your financial resources. You know, couples often plan to travel and do all kinds of things, buy a second home, and now they have to regroup and think differently about that. They might have the loss of previous relationship qualities, where one person, you know, had a certain role and now they have to be in the position of authority over somebody they don't want to have authority over in some domains. So these are some quotes I've gotten from working with my patients over the years, and I think it puts some of this into perspective. I feel like her doctor's given up on her. He stopped looking for other causes for the medical symptoms. This isn't how we plan to spend our years. I want to feel better about the future. Nothing I do seems as it used to be. I feel isolated. I never plan to retire. I just want to get normalcy back. So ideally, what we want to do is have people do all of these things while they're in the bubble, so that then they can escape the bubble and kind of right-size the illness into not being everything in their lives, right? So we as providers have a way, a responsibility to try to help them do that, so that their only role isn't the sick role, right? And we want to try to restore as much as we can. So people with illness and their family members may have to enter this bubble more than once, right? Sometimes there are different phases and you get things in place after, for example, an early Alzheimer's diagnosis, you get things in place, go back to life as you know it. And then when things start to change, might have to revisit and do some different plans. So now I want you to think about an alternative scenario. When someone, it's often the patient, but doesn't have to be, won't go in the bubble. Okay, this is the person who is avoidant, doesn't think that there is anything wrong, or doesn't want to talk about it, has shut down, is avoiding it. Imagine what that does to the other people in the family who are trying to do the planning and the hard work and all of this kind of stuff when somebody is saying, I'm not going along with you. That happens a lot, right? And I think that in the first scenario I described, with everybody going in and doing all of that, all of those things, those are usually high functioning families, right? Not all of our families are high functioning. And it's actually much more difficult for providers when there are people who are unwilling to accept it and kind of move along and step with everyone else. So now I want to talk a little bit about family dynamics and care delivery. And when I think about family dynamics and family therapy, I'm a medical family therapist. So if someone comes to see me in the dementia clinic, I'm not going to be dealing with their trauma, for example, from a long time ago, unless it relates to the issue at hand. So in my context, and I think this applies to your context as well, I want to focus on the family in terms of whether and how they can support your team's plan of care, right? So we're going to be looking at family dynamics as it relates to, if you're putting together a plan of care for your patient, can this family do what you need them to do, right? Or are you going to have to bring in other resources? Are they part of it? Do they have what it takes to do that? So that's the context that I'm going to frame this in. All right, one slide on Family Systems 101. This comes from Dr. Murray Bowen, who was a psychiatrist and really one of the fathers of family therapy. He worked with schizophrenic patients mostly. But family systems principles are that the family is one cohesive emotional unit, that everybody in the family has roles to play and rules to follow, whether they're spoken or unspoken. Patterns develop so that each member's behaviors affect others in predictable ways, right? We rely on certain family members to behave in certain ways. Families like predictability, so the system seeks homeostasis, and any interruption or movement in this system knocks everything off balance. An example of this might be my mom had been diagnosed with cancer many years ago, and there are 4 of us, and my one sister was the one with my parents in our hometown. And she said that we all reacted in our own way. We all had our role to play, right? I have a sister who's an attorney, and she's always challenging things and wanted to get a second diagnosis and bring my mother to New York, where the only place where there were good specialists. You know, she went into full-blown sister mode. And my brother, he always worked as a data analyst, so he wanted to know the data. And I said to my sister, well, what do I do? And she said, you wanted to know how everyone was doing. I thought as a family therapist, that would be appropriate, right? So we all kind of fall into these things, and we usually behave as expected. So there's not a huge literature, but a growing literature about how family function affects health outcomes. And we know that family dysfunction affects conflict, and conflict affects dysfunction. And there are starting to be more and more, although I wish there were more, studies about how important it is to understand the family and how the family's functioning really does affect healthcare outcomes for the caregiver, as well as for the patient with the illness and the provider-patient relationship. But there is a literature base that supports that family conflict increases caregiver burden, it results in poorer family functioning. It results in depression, anxiety, and anger, and poorer outcomes for the person with the illness, whether it's memory problems, behavioral symptoms, decreased function. If someone is afraid that someone's going to yell at them or disapprove or criticize them for doing something, they often recede, stop doing anything at all. So that's just an example of how behavioral symptoms occur when somebody, might be in a situation in which they don't feel safe. So I'm going to just describe what family functioning is. There are 6 domains that family therapists often think about in terms of family functioning, and these come from something called the family assessment device, which is used in research. So the first is communication. And that's just, do family members speak in a way that's clear to one another? And do they say what they mean and mean what they say? Problem solving is how much the family's ability to solve problems helps to maintain their function. Role performance is, do people do what they're supposed to do or expected to do in the family? Right? Whether they have assigned tasks and whether they carry them out responsibly. If a caregiver says, I'll bring mom dinner every Wednesday night, can you rely on them to do it? That would be an example of role performance. The other ones are affective response, which is how comfortable do family members feel to express appropriate affect in the range of different types of stimuli. Sometimes families want everyone to see them wrapped up with a bow. And I'm sure that as providers, you've often seen that. Families try to bring their best selves to you sometimes, and they don't want you to see what's really underneath that. So you want to understand whether or not they feel appropriate, they feel like they feel comfortable expressing how they really feel in different types of situations. Affective involvement is how much they care about one another. Do they take an interest in other people's concerns? And behavioral control is, what do they do to keep the family functioning the way that it functions? You know, is it an appropriate control, inappropriate control? And I think in our work, it also has to do with how people use resources or financial resources. And sometimes there's the potential for elder abuse in terms of how people are using control. That's for a different lecture. All right. This is another silly little thing that I developed years ago, mostly for teaching, that looks at the anatomy of a family at any point in time. And this is what I consider a basis for a family assessment. And imagine these little smiley faces are people in a nuclear family. And if we go look at the pink arrows, everyone is in their own developmental stage. If you think of Erickson or whatever, right? Everybody's in their own place in terms of human development. And then if you look at these vertical lines, there's the green box, the blue box, and the purple box. That if somebody in the family is a young adult, this family has life cycle tasks for a family with a young adult. If they also have somebody in midlife, then they have tasks that they're focused on for midlife. And if they have an older adult living with them, they also have tasks for a late life family. For a young adult, it might be getting somebody to school, providing after school care. In midlife, this person might be at the pinnacle of their career and have a lot of responsibilities going on, might be in the sandwich generation. So they are trying to figure out who they are personally, professionally. A lot of things go on in midlife. And in late life, this person might have a chronic illness, might be the caregiver to the young adult. There are different things that go on there. These dotted yellow lines that come down vertically are the intergenerational patterns. How we think about how a young adult should be cared for is often influenced by the people who came before us, might be our culture, ethnicity, race, religion, whatever. So our views about how we carry out these tasks are shaped by intergenerational.
Thank you. You're welcome. Have a good weekend.
Josh, would you mind meeting everyone except Carol?
Okay, thanks. And then the other thing is where it says family relationships on the bottom, we want to know how the different people in this nuclear family get along. And in terms of family systems, we want to know who's in charge, right? We've all heard of the parentified child, or, you know, is it a mom who's taking care of everything? Is there a single parent involved? Is it the grandmother that was coming to live with the family that's involved? How is the family system organized? And then this oval dotted line around it is really, this family is in the context of an environment, whether it's a community, a neighborhood, a culture. And I think all of that comes to bear. So that was a lot of words that just says what I look at when I take a snapshot of a family. So this is from the Family Caregiver Alliance, and it says that today medical advances, shorter hospital stays, limited discharge planning, and expansion of home care technology have placed increased costs and care responsibilities on families who are asked to shoulder greater burdens for longer periods of time. I'm not going to go through all of these, but these are examples of the kinds of roles family caregivers are asked to carry out. And just by a quick glance of them, you can tell that the skills for doing these things are not in everyone's wheelhouse. Some people may be good at handling the bills or the finances, but might not be good at playing the role of the care coordinator or advocating for their loved one during a medical appointment. So there are a lot of things that happen. And these are really the kinds of things that we ask people to do when we're developing a plan of care. I have a whole talk on the cost of caregiving looking through this wheel, so we're not going to do that, but I just want to call attention to the domains of caregiving costs. We know that it takes a toll on physical health. Depression rates are a lot higher for caregivers. They lose a lot in terms of economics and worth and net worth and value by turning down opportunities for promotions, having to cut back to half time, not having as much money put into their 401ks. They also, by taking care of a loved one, miss out on other family ways to engage with other people in their families, might interfere with going to sporting events for kids or other kinds of stuff. It's very isolating. People report losing a loss of their selves. And actually there's evidence that shows that the mortality of particularly dementia caregivers is higher than that of caregivers for other illnesses. So why do caregivers provide care? Well, there generally falls in 3 buckets. Attachment, right? They care about people. They love the person. They wouldn't think of not doing it. Then there's obligation. And that often comes from cultural things or your role in the family or what your parents expect of you. In some cultures, if you're the youngest daughter, tag, you're it, right? There's no discussion. So a lot of times people do it with a feeling of obligation, or sometimes it's an obligation by guilt. I could never have a stranger take care of my mother, for example. And then there's exchange. If I do this, perhaps I'll get that. So here's a few articles that I found that are kind of recent publications about family functioning in chronic neurological disorders. So this one looked at caregiver burden and functioning in this array of illnesses. And they found that caregiver burden differed by illness, with ALS and brain injury being the highest, then AD and PD, and then MS. But the takeaway was that family cohesion, satisfaction, and quality of communication were associated with reduced levels of caregiver burden, whereas when family members were disengaged, that's like the person outside of the bubble, that was associated with higher burden. This article highlighted the importance of studying and treating caregiver burden within the context of family relations. Here's another one that was exploring the unmet needs of family members and patients with PND. This was a focus group, a qualitative study, and they also found that the lack of information about the disease and available support resulted in a deterioration of mutual understanding between the patient, family, and medical staff, and increased stress for the caregiver and lowered quality of life for the family. So they concluded that family members expect health workers to provide them with support, which includes informing them about the possible help available from the health and social welfare systems. In this one, it was done in Pakistan, and it was about functional neurological symptom disorder. And they were trying to better understand the lived experiences of people diagnosed with this. The themes that they uncovered were quarrels and unexpressed emotions. And quarrels included those with family members within the family, extended family, as well as parental and marital discord. And unexpressed emotions were often hurt, anger, sadness, and jealousy. And they concluded that stressors related to the family serve as significant contributing factors in the development of FNSD. And this last one looks at a severe rare chronic neurological disease, and it illustrated that this disease affects mothers in particular, but also the entire family. It underlined the need for personalized care and counseling of parents and families following the diagnosis and during the end stage in a child with severe rare disorders. And I emphasize here personalized care and counseling, and you'll understand why as I move on. some of you might be familiar with Leonard Perlin's stress model. It was developed originally in 1990 to look at what just a model of how caregiver stress develops, what perpetuates it, and opportunities for intervention to reduce it. And this is a model that's continued to be in use today. And I just wanted to share here that what I'm talking about today looks really at the role of family relationships as secondary role strain. And if we can intervene to do something there, perhaps we can affect outcomes. I found this a while ago, and it really encapsulated my view of how we need to work with families with chronic illness. And I think the bottom line of that is that patient-centered care is not enough. This came from a New England Journal of Medicine article, and it was, I'll just read some of it. Many caregivers have persistent depressive symptoms, which reveal the reverberations of illness beyond the index patient. This article highlights the need to revise the view of the patient from a solitary figure to a person embedded in a social network. This approach identifies various persons around a focal person and elaborates the structure and characteristics of the relationships. This method explicates how a patient is situated in a complex social connectome that is made of strong and weak relationships, kin and non-kin, and persons with varied health habits. And I plan on explaining and expanding upon this thought. So why do we need to go beyond patient and family-centered care? Well, let's look at what it is. The Institute of Medicine in 2001 said that patient-centered care was being respectful of and responsive to individual patient preferences, needs, and values. It was honoring patient and family choices, including them in decision-making, sharing information, and collaborating across care settings, so there was continuity. A brief definition of family-centered care is developing and implementing patient care plans with family participation. So what's missing? I think acknowledgement of the family caregivers and other family members' biopsychosocial needs, and an assessment of how family relationships, behaviors, health habits, and resources may affect the person with the illness. So this is something, I just had a paper published in Frontiers in Psychiatry where I propose a new model for family-framed care, which goes beyond patient-centered and family-centered. And if you look at the individual level, right there where the person with dementia and family caregiver are in the individual level of this social ecological model, you can see that in patient and family-centered care, they're both lumped together in that one thing. The family caregiver is not separate. The family caregiver is viewed as just an extension of the person with the dementia. The assessment and treatment strategies focus on the needs of the patient in the individual level and not within the context of the relationships or the environment. In reality, the patient with the illness and the family caregiver each are in their own social ecological system. And yes, there is some overlap, but they have some overlapping, but also very different stressors and very different resources and relationships. So we're not going to go into this whole thing, but I will be talking about this at Geriatric Medicine Grand Rounds in March. But this is my model for family-framed care. And this is taken from the paper that explains this case study. But what I'd like to do is focus on that blue, what's contained within the blue dotted line circle, right? Where we need to really understand the biopsychosocial factors of the person with the illness and those of the caregiver, understand both of them in the context of their relationships, and understand the relationships between the two relationship circles. I think that if we have a better understanding of those things, we can do a better job of implementing a care plan that serves the patient, that also supports the caregiver, and more than anything else, increases the likelihood that the plan of care that you develop in your offices is actually implemented. So let's look at some interventions for working with families. I think the first step is to learn about the family. And the first point I'd like to make is the context matters. You look at these different people, would you serve each of them? Would you address each of them in the same way? Probably not, once you see the dynamic that's going on. Again, from my practice notes I've taken. My mother left when we were young, and now she expects me to take care of her. I would like to know if my husband's dementia was caused by his years of alcohol abuse. If it wasn't, I won't have a problem taking care of him, but if it was, we got along fine until my wife had to stop drinking due to a medical condition. Then she was diagnosed with dementia. My husband had an affair for the past 20 years of our marriage, and now I'm expected to give up my life to take care of him. So if we don't understand these things, we miss out on how all in somebody is in terms of being a caregiver, right? It goes back to their reasons for being a caregiver and how much you can expect or ask of them. So I think it's important to have some kind of understanding of this. Of course, it takes a relationship with someone to be able to get to this point where they feel comfortable sharing this. But you can see how these kinds of things could alter how you deal with a family and put together a plan of care. So when I do a family assessment, and in addition to that, this is kind of like fleshing out that anatomy slide that I have there. So I like to think about who is considered family. And then of course, certain considerations, the ages and functional ability of the persons who would be a caregiver, what other kinds of obligations or occupations or things do they have that might get in the way, that might facilitate or get in the way? Where is everybody? Do they generally have good relationships? Are they financially independent? Is the person with the illness financially independent, or are those taking care of the person dependent on them? And that's a very, very important factor. Are they emotionally independent? Are they allowed to feel and express how they really feel? What is the caregiver's health status? Do they have mental health issues, a substance use disorder, anything else that would get in the way? Is there a history of abuse or trauma? Is it among the people in this particular family? What other sources of support, community connections, do they have that we could pull in? And in terms of caregiver considerations, I look at the relationship history between the care receiver and the caregiver, the person's motivation for caregiving, again, that financial independence piece. And what is the caregiver's perceived role in the family? One thing I often call attention to is that in medical settings, we often assume that the person who brings the person to the appointment is the caregiver and often note that in the chart, when in reality, that might just be the person who has Tuesday afternoon off and can do it, right? The other thing is sometimes the person who brings the patient to the appointment is not the healthcare proxy and doesn't have power of attorney, because that might be, the brother in Chicago. So that person might be the transporter, but really not have any functional role of authority in the family. We often don't ask about that. Then there are sociocultural considerations that emanate from race or ethnicity or religious tradition, education, SES, their health literacy level. And then I like to know, thinking again about the bubble, is there family agreement that this person is in need of help? Is everybody all in? Are the care receiver's wishes and care preferences known? And Benzie, you got to know about this one, right? Do the family members support those wishes and care preferences? So the next thing I look at are the structure, rules, and roles, right? So what are the relationships that the caregiver and receiver have with each other and other family members? Are the caregiver and care receiver a dyad and everybody else just lets them be? Are there other people who think things should be done differently? Do they keep everybody else out? Do they invite other people in? There's a lot of interesting dynamics there. Who makes the decisions regarding care and finance? Who has the formal or informal authority to make the decision? Is it one of those family of origin or cultural traditions where it's patriarchal, matriarchal, youngest, oldest? Whose opinion matters the most in this family? Who is the influencer? And what are the family's cultural rules and values about what's expected of a child regarding a parent, or what's expected of a parent regarding a child in terms of caregiving? What are the rules about discussing legal and financial things? In some families, it's not allowed and it's off limits. What are their ideas about privacy and using strangers as helpers? And what about social services and healthcare professionals? How do they feel about them? Is their communication open and clear? Are there a lot of off-limit topics? Often death is an off-limit topic, as is financial stuff or emotional expressions. In some families, expressing happiness and appreciation and gratitude are okay, but you're not allowed to express negative emotions that cause trouble. Then we want to know, what is their understanding of the illness? What do they think has caused this healthcare problem? Why do they think it occurred now? What do they think the illness does to the patient? Do they think it's severe? What kind of treatment do they think they should receive? This is where, when people go into the bubble, they might be reading about all those things. They then come to your office to ask about. I read about this, and in Mexico, they're doing this. I read about this drug, right? People will read about things and develop opinions about what they hear from other people and what they find on their own, and it might be in odds with what you're telling them. What are the most important results they think the patient should obtain from treatment? What are the major problems the illness has caused for the family? And what do they fear the most? And then I think the last one is the family's previous illness experience. Did they ever have a serious illness? What was their story about how they coped with it? What were the outcomes? And this might affect whether or not they want to go to the hospital or would go to a nursing home or an ED or on hospice care. How did it shape their perceptions of medical and healthcare professionals or healthcare settings or advanced care planning, right? What is the meaning of illness that they have as a result of this? And then the last one is, what do the patient and family think are the most important things they need to know? Do they know others with the same healthcare problem? Do they understand and agree with the treatment plan? Are there physical or cognitive limitations that will be barriers to them learning what they need to know? Are they willing to negotiate goals with the healthcare team? And are the patient's perceptions about what to do similar to the families? And I just want to call attention that this is really the essence of the what matters question in the age-friendly System 4M model. You're just really trying to understand the nuts and bolts of what matters to that family. So where do you begin when you have all of this stuff? Well, this is something that was done by people in Rochester, some of my former colleagues, Cleve Shields, Deborah King, and Lyman Wynn. And it's a very interesting little kind of a flow chart that says where you begin. So for example, if we look at level 1 and you're seeing a patient in a family who love and care for each other and they communicate well and clearly and they're good problem solvers, then an example of interventions would be give them education, information, and refer them for support because they're doing well. But if you go to, for example, level 3, where they have good attachment, but they don't communicate so well and they're not good at problem solving, then you might need to work harder at teach back communication skills and find the best way to for them to deliver and receive messages. So I think this is just an interesting little thing to think about, that there are levels when people come to us in terms of these things, and we need to have a different approach for each type of family. So now I want to dig deeper into the referral process. So we know that a lot of the care plans that we do include a medical component, and they also include a support component. And the support component might also involve human services, but it also might involve referring people to other providers. But I mostly want to focus on support services. So we know that support services really do make a positive difference in the lives of family caregivers. I don't have citations for all of these. I can certainly give them to you if you want them. But for the purpose of this presentation, I think it suffices. We know that they improve caregiver skills, self-efficacy, and coping, as well as caregiver well-being. They decrease symptoms of depression, anxiety, and burden. They decrease rates of or delay institutionalization. That's a lot of Mary Middleman's work. They improve the quality of life for people with cognitive impairment. They improve family relationships and function, and they help to connect families with benefits. Yet, while we know all of that, we know that there are about 67 million informal and family caregivers providing care to people who are ill, disabled, or aged in the US. 66% of older people with disabilities get all of their care from family, mostly wives and daughters, without support services. 26% receive some combination of family care and paid help, and only 9% receive paid help alone. I did this little study in the memory care program years ago that just looked at recommendations that our physicians made for, well, I looked at 49 patients. And I found that 87% of the medical recommendations were implemented, but only 69% of the social or behavioral recommendations were implemented. And the least likely were any involving formal services. And the barriers to the recommendations sometimes were a patient barrier, refusing to go, or a family barrier. I think often hear of, for example, daycare or taking a driving assessment or taking keys away. You know, when somebody in the family is maybe an adult child and they don't feel they have the authority to tell a parent what to do, I would consider that an example of a family barrier. So what affects service utilization? Well, it's often not money, and this also comes from a variety of studies. It's another paper that I'm working on, but it's not about money. It's often, we found that greater availability of services doesn't matter. The amount of caregiver burden does not always equate to a caregiver's perceived need for service. The care receiver need and caregiver characteristics do drive utilization. Culture matters, motivation matters, and beliefs matter more than resources and need. Beliefs about, do I need this? Beliefs about, is this the best way for us to spend our money? Beliefs about strangers caring for loved ones. And of course, family dynamics matter. So I want to dig into referral practices because I think this is really important about how we make referrals. Currently, we generally, I can speak for Alzheimer's, how we deal in the memory care. We assess we send people to information and referral services. They assess the needs of callers, information relevant to the question. In other words, sometimes a physician will say, call the Alzheimer's Association. So they call the Alzheimer's Association and they say, how can we help? And they say, my physician said to call. So this goes to often not explaining why you want them to call or how you think it would be a benefit. Another model is social workers often make the referral directly to the association or offices for the aging. And sometimes the physicians make the referral, and sometimes they might address the psychosocial history. Sometimes they might give a prescription. They might indicate it in an after visit medical summary, or some places make a direct office to office referral. So the current referral paradigms and practices are usually flat, categorical, linear, one size fits all, some kind of a checklist. And providers seldom identify the target for the intervention when making the referral. And if you looked at, for example, prescribing an antidepressant, you would have a rationale for why you were doing that, what neurotransmitter system you were trying to target, and what symptoms you were trying to target. We don't do that when we make referrals. It's kind of like just adhering to the standard of care, but it's like hoping it'll hit the mark without identifying what mark you hope it will hit. Then the next is time constraints and low reimbursement rates push us toward these directives and away from dialogue, actually talking about how this could help. And a little bit about why the current approaches aren't always appropriate. Regarding diagnosis, if the person isn't ready to hear or accept a diagnosis, they're not in the bubble, their likelihood of seeking education or support is nil. Not all illnesses are diagnosed in early stages, and yet when you have those algorithmic models of what you need at what stage, sometimes they don't match the needs of the person coming to see you for the first time in the middle of an illness. The beliefs about illness are often culturally determined, and so the meaning is ascribed to the symptoms can vary by faith or culture. It's not always regarded as a medical phenomenon. Sometimes, for example, dementia is regarded as the work of the devil or not being saved, and they don't think that any kind of referral is going to make a difference. And coping styles vary. Those who rely on emotion-focused coping need time to wrap their head around moving toward a more problem-focused approach. Now let's think about at the family level. Each family system, again, has its own rules, power structure. Again, these things are often culturally determined. Not all family members have the authority to act in the ways we encourage. And communication and problem solving are first learned in families. Family history of illness matters. I always like to call attention to the fact that not all couples resemble those loving couples in the Aricept ads. Family conflict is prevalent in families with chronic illness. What appears to be avoidance may be inability to reach consensus or may reflect some other learned behavior about not rocking the boat. And now the client factors. Psychosocial assessments often focus on the needs of the person with the illness, assuming that meeting his or her needs will hit the mark for the caregiver. But it's unlikely that the needs of the person with the illness and caregiver and the family are all the same, as I showed in those social ecological maps. Perceptions of doctor-patient relationships vary, often by generation, by family, illness experience. There's also been a shift generationally toward partnerships away from authority figures, and I think that's an important consideration. And we always have to pay attention to health literacy levels. So our current referral paradigms, I believe, are often rooted in the we know what's best for you approach rather than in a more collaborative approach. I think a way around that is, and I understand that in most of our systems now in URMC and neurology as well, they're moving toward embedded behavioral health providers. And I think that is a great addition, because if you can do a level 1 or 2 family by just giving them education or referral, that's terrific. But sometimes we have to work on behavior change and readiness to change and stages of change. That's where, in the green there, assessing and providing support for behavioral health or change intervention is really important. So I think that we're moving toward that. I'm going to just go past that for the sake of time. The next thing I want to talk about are psychotherapeutic interventions. The first thing to consider is that adjustment to a chronic illness takes time. Adjusting to a medical event is a process for everyone involved. So we really need to consider the stages of change when making treatment recommendations and really dose it and right size it to what people are ready to hear at that time. It might slow things down, but it will be more effective in the long run. The other things with families who are struggling with this, they often want to put the person in the sick role or don't know how to look at the person for the strengths he or she may still have. I often ask people to think about what strengths they have and what they can do rather than what they can't do, and try to help the family organize around helping them succeed by giving them tasks that they can participate and succeed in. So I often like to think about illnesses as unexpected guests because it helps to recognize that the person with the illness is a person and not a symptom, that the illness is an inconvenience for everyone, including the person with the diagnosis. And it gives family members a way to talk about illness without making it feel so personal for the person with the illness. Sometimes we can switch perspectives by listening to family stories about some things that are better or positive things that have happened as a result of an illness. So go from the unraveling to weaving something new. Another one is moving coping styles from emotion-focused to problem-focused. Emotion-focused coping tries to deal with the emotional responses people feel, like fear, anxiety, and problem focus usually targets stress in a practical way by trying to get rid of the cause of the problem. Studies have shown that caregivers with problem-focused coping have better health outcomes and feel more confident as caregivers. These are examples of emotion-focused and problem-focused approaches. I'm rushing now, so I'm happy to share these slides. This is my last one, which is something I'm also working on, which is an example of family-framed approaches, thinking about who is your care recipient for the particular visit you're having. If it's a diagnostic visit, it's probably patient-centered. But if it's in the middle of a chronic illness, or particularly in palliative care, it might be the patient and family. And there are different approaches for each of them. And I think it really helps to identify who the care receiver is for that particular visit. That was a lot. And I could do a lot more. But anyway, was that of any use? Does anybody have questions?
Yeah, I mean, yes. My name is Charles. I was diagnosed with multiple sclerosis 6 years ago. And your presentation was spot on to a lot of the problems that I have, I'm gonna say, overcame. Mm-hmm. First of all, I want to speak to overcoming the disability and accepting and then healing for a person that has to deal with one's, one second. After overcoming the shock and the disbelief, and then the acceptance and healing for one that's diagnosed. And then we persons with that diagnosed have to deal with how others value and see them.
Right.
Then that creates a whole nother burden for that person with the disability. Mm-hmm. And then I want to speak to when there is no family. I don't have a family at all. I have no caregiver, no relatives, no one that I could pretty much say, come help me. So with a person that has no family, that person has to rely on their self, their spirituality, and then the system. So when the system fails, when the system fails that person, it creates a whole nother issue of burdens. or problems that that person that's sick has to deal with. And then with personalized care, I think I fall in the 9% because I don't receive any support.
Right.
So, and then I want to speak to strange or strained relationships within family dynamics. I have a son, and we have a strained relationship all of our lives. And now I'm at the stage where I may, want to rely on him to help me, especially as I get older or as the disease progresses. But I don't trust that. I don't trust him taking care of me.
Right.
Because of the strained relationship.
Right.
So I guess that puts me at level 5, right?
Well, that's from a family perspective, probably yes.
Yeah. So
yes.
So, and then I want to speak to the paradigm and the practices and how I had to adjust and not focus on my condition, but put a more focus on the problem to try to, get rid of the problem. Here's an example. Before I got diagnosed, I like to sleep under the covers, under the sheets, real snug. But since my diagnosis, I can no longer do that because it's difficult for me to get out the bed.
Right.
So instead of being focused on, wow, I can't get out the bed like I used to. So now I tuck all my sheets under and just sleep with the comforter over top. That way I'm in and out the bed, a little more efficiently.
Right.
So I just wanted to, speak to those.
Charles, I think that you made me realize that we also maybe need to focus on patients who don't have families and what that's like for them. So you've given me a new perspective to think about all of this, a new lens for this. And that's very, very important.
Yes.
Thank you.
Yes. And then I think with those who don't have family, I think PCC and then PC could be combined.
Right. That's where patient navigators and other people can help too, right? I think we have a future meeting set up in another context, so I'll look forward to those conversations. I know Dr. Walpole's setting something up, so I think we can connect some more, Charles.
Okay,
does anyone else have a question?
No one else does, and definitely welcome people. One of the things that struck me, which I hadn't really thought about consciously, is kind of the types of handoffs that occur. And that, as you said, people, may or may not fill their prescriptions, but they, very often don't follow up with counseling, don't follow up with other things. And I don't know if this is the right lens to look at it, but I'm wondering what your thoughts are of the healthcare team kind of becoming part of the family.
Right.
Because I've found like at Colorado, and I think here, that the more involved the team is, the more likely solutions are to be followed up on, as opposed to, it's not the same as giving somebody a prescription, that there's going to be kind of a different level of investment. And I don't know if that ties into or expands your model, or how that's your approach to it.
I think that understanding more about how to do that and creating that sense of family would be a really good addition, especially for connecting people to services, because right now it's usually the handoff without all of that. And that makes such a difference. I think that's a really important thing to explore. Anything else?
We've had I don't know if you've been looking at the chat, but a lot of accolades, which I agree with, and it's been actually a wonderful talk. I had I think a lot of people have been thinking about things in terms of caregiver burden, but not in terms of family dynamics. Although I think, and part of the reason for inviting you was seeing how family dynamics oftentimes I feel like even maybe ossify or get under the stress of chronic illness, create even more problems than they had before. So it's
and I think also systemically how our systems really treat family. We don't often ask for, if you'd like, I'll share the slides with Benzie and he can distribute them. That last slide that I had that was hard to read has questions on there where, when I get to meet with family members, with patients, sometimes they'll say, I don't really want that person talking for me or telling how my function is. And we don't ever ask the person, how do you feel? These are like informed consent. These are the questions that I would like to ask of somebody who knows you well. Who would be the best person to do that? The person who comes with them might have some, secondary gain to benefit them by answering in a particular way. And sometimes patients will say, I don't trust that person to speak for me. But we don't ask that, and there's so many things like that I think we really need to work on in our system so that we're really protecting the caregivers when we need to and protecting the patients when we need to. So family dynamics are sticky and complicated, but thank you so much for the opportunity to share with you. And I hope that we'll have a chance to do something like this again.
Oh, thanks so much. Yeah, very, very eye-opening. Take care.
Thank you very much, Carol.
My pleasure.